These are some of the sights and sounds of Pennhurst, the state institution for the mentally retarded. It's located in Spring City, Chester County. In 1908, when the institution first opened, the man in charge bitterly complained to the state that the conditions were already overcrowded. He transferred many of the patients to Q1, a classroom building. Many of them are still there.
At the dawn of the 20th century, reform in America carried the language of progress. Industrial cities were swelling, immigration was reshaping communities, and poverty and disability were no longer viewed as private misfortune, but as public concerns requiring organized response. In Pennsylvania, that response took institutional form. In 1908, the Commonwealth opened the Eastern State Institution for the Feeble-Minded and Epileptic in Chester County. The campus covered 633 acres of farmland and rolling hills. Later, it would be renamed Pennhurst State School and Hospital. Its creation reflected more than charity. It reflected ideology. The progressive era embraced scientific management. Human difference could be measured, categorized, and corrected. The emerging eugenics movement, widely accepted in academic and legislative circles, argued that intellectual disability, epilepsy, and defects threaten social stability. Segregation was presented both as protection and prevention. The language used to describe those confined within these systems reflected that ideology. Physicians and administrators divided people into three official classifications: idiots, imbeciles, and morons. These were not casual insults, but clinical categories used in institutional records, medical charts, and court commitments. A single label could determine where somebody lived, how they were treated, and whether or not they would ever return to the outside world. Pennsylvania was not unique. By 1910, nearly every state had established large-scale institutions designed to separate those deemed unfit from the broader population. Pennhurst was designed to house 500 residents. Within 15 years, more than 1,500 lived on its grounds. Expansion followed demand, not evaluation. Families petitioned courts for commitment, county officials authorized transfers, and judges approved placement. For many working-class households, institutionalization was presented as a medical necessity. What began as reform quickly became infrastructure. Pennhurst did not emerge from cruelty, it emerged from certainty. Certainty that science could reorganize society and that the state could manage what families could not. That difference required confinement. This is the story of how that certainty unfolded. Institutions require administration. Pennhurst operated under Pennsylvania commitment statutes allowing the involuntary placement of individuals diagnosed as feeble-minded, epileptic, or otherwise incapable of self-support. Medical certification and court approval formalized admission, but diagnostic thresholds were broad. Children as young as 5 entered the system. Release required institutional approval. Discharge rates remained low throughout the early decades, producing a steadily accumulating population. By 1923, official census records listed 1,546 residents. By 1945, that number had risen to 2,791. By 1966, the population exceeded 3,500. Administrative leadership oversaw expansion. Superintendent Dr. Martin W. Barr, an influential and early advocate of institutional segregation, promoted the belief that structured isolation served both the individual and the public good. Under successive administrations, construction projects added dormitories, workshops, and medical facilities to accommodate growing numbers. More than 30 major buildings eventually composed the campus and was operated as a self-contained municipality. It maintained its own power plant, water system, farms, and workshops. One of those buildings, Philadelphia Hall, was at one time the original administration building, but transitioned to house the institution's physicians and clinical offices. Among those physicians was Dr. Jesse Fear, who played a key role in evaluating residents and overseeing treatment plans. With its close proximity to the new administration building, medical personnel kept administrative oversight close at hand. Beneath the campus, another system operated largely out of sight. Pennhurst buildings were connected by an extensive network of underground service tunnels known today as the Rockwell Tunnels. Part tunnel, part passageway, this underground labyrinth carried steam pipes, electrical lines, and maintenance infrastructure across the grounds linking dormitories, medical buildings, and administrative facilities. In some sections, the tunnels rose nearly 10 feet high and stretched for thousands of feet, allowing staff to move equipment and supplies between buildings without crossing the open campus. Above ground, the daily operation of the institution depended heavily on patient labor. It was known that if a patient could work, they contributed. Residents labored in kitchens, laundries, agricultural fields, and on maintenance crews. Work was described as vocational training, yet it sustained daily operations. Pennhurst also included communal spaces for its patients. In 1929, the assembly building was completed, serving as both a gymnasium and an auditorium. Here, residents gathered for exercise, assemblies, and programs, a rare space designed to foster activity even amidst the regimented environment of the dormitories. Also located on the property were dedicated facilities like the maintenance building, where tools, workshops, and repair operations kept the institution running. Every pipe, engine, and structural repair passed through these places, underscoring how Pennhurst was engineered to function as a self-contained world. State appropriations, though, rarely kept pace with census growth or facility deterioration.
I also spoke with the business manager here at Pennhurst, Elmer McSurdy. I questioned him on the cost of repairing the buildings.
Can't touch a building unless you're ready to spend $1 million or $1.5 million. Now, as long as the buildings stand the way they are, the law doesn't require that they come in and close it down.
Some of them should be closed down, shouldn't they?
I presume if the labor industry were to inspect them as they stand now with the idea in mind that they must meet their requirements, they would be closed.
Could you tell us a little about the problems you have faced purchasing necessities since Pennhurst has been on its most recent austerity program? Could you tell us a little about the situation with the braziers?
Well, there was an order for braziers. It was canceled. We were given the opportunity to justify the requisitions.
How did you try to justify it?
Embouchures. Well, on that one, I just wrote self-evident.
What happened then?
It came back with a large group of requisitions for more justification.
More justification. Did you justify it further?
I had one of our doctors write a justification.
Did you finally get them?
No.
During the 1950s and 60s, budget reports documented repeated funding shortfalls. Staff salaries remained low compared to the private sector wages. Turnover among attendants was frequent and vacancies went unfilled. By the early 1960s, some wards operated with one direct care attendant supervising more than 60 residents during daytime hours, and night shifts were thinner still. Oversight mechanisms existed but were limited. Annual inspections from the Department of Public Welfare recorded overcrowding and deferred maintenance, but did not mandate population reduction. The system expanded because policy encouraged placement and offered no meaningful alternative. For decades, this remained largely invisible beyond institutional walls. In 1968, that changed. Bill Baldini's investigative report, Suffer the Little Children, broadcast on WCAU-TV, exposed overcrowding, neglect, and institutional conditions inside Pennhurst State School and Hospital through raw observational footage. The program showed residents living in unsanitary conditions, severe understaffing, and the psychological effects of institutionalization, shocking the public and sparking widespread outrage. The images contradicted decades of official reporting. Public scrutiny began not with reform legislation, but with a camera. If administration built the system, medicine maintained it. The infirmary functioned as Pennhurst Clinical Center. Every admission passed through its examination rooms where physical assessments recorded weight, height, motor ability, and mental history. Psychiatric evaluations assigned diagnostic labels, and intelligence testing produced numerical classifications that followed residents permanently. Categories dictated housing placement, work assignment, and supervision level. Early institutional records revealed that a significant percentage of residents were admitted for epilepsy. Seizure management required ongoing monitoring, and phenobarbital became a standard treatment in the early 20th century. By the 1950s, antipsychotic medications such as chlorpromazine were introduced to address behavioral disturbances. Medication logs grew extensive, and as population increased, medical demand intensified. Tuberculosis screenings were routine in early decades. Respiratory infections spread rapidly in crowded dormitories. Skin conditions and nutritional deficiencies appeared in inspection reports. Injury treatment was common in wards where limited staff supervised large groups. By mid-century, licensed physicians on campus were responsible for thousands of patients. Registered nurses were even fewer. Attendants without advanced medical training carried out daily supervision. Average length of stay extended across decades for many residents. Children admitted in the 1920s aged within the institution rarely transitioned to independent community life. Mortality records reveal consistent annual deaths, particularly during peak census years, with causes including epilepsy-related complications, pneumonia, cardiac disease, and infections. Death certificates were filed, and burial typically occurred on institutional grounds. Annual statistical summaries justified budget requests to Harrisburg. Numbers demonstrated necessity, and that necessity justified continuation. After 1965, federal Medicaid funding under Title 19 began reimbursing certain institutional costs. Rather than shrinking census numbers, new funding streams stabilized them. The infirmary did not merely treat illness, it processed population. It converted human variability into data, that data into policy, and that policy into permanence. Medicine supplied legitimacy, and the state supplied custody. Large institutions reshape behavior. Dormitories housed rows of beds in open wards. Personal possessions were minimal, and clothing circulated communally through central laundry. Developmental research later demonstrated that prolonged institutional living affects cognition, emotional regulation, and social attachment. During Pennhurst peak decades, such findings were not yet integrated into policy. Residents experienced life according to schedule. Bathing was rotated through limited facilities, and outdoor recreation was minimal. Education programs on the ground served only a fraction of those eligible. In the entire facility, there was only one carpeted room. It served as the visitation room and was separated from the wards where most residents lived. It was one of the few spaces designed to feel comfortable to those who came from the outside. A facade to mask the real human suffering.
People seldom think of food as being a problem. I spoke to the dietitian here, Elizabeth Roberts.
We have some patients who cannot tolerate whole food. We have to puree that food, but they get a well-balanced diet. We puree meats, vegetables, and we try to put bright color in this pureed mass of food so that it is attractive to the eye. You know, they say eye appeal and taste appeal is, that's what we strive for.
Individuals rocking, self-stimulating, or sitting motionless for extended periods were often interpreted as systems of disability rather than responses to environmental deprivation. Family involvement varied wildly, with some parents visiting consistently, while others were advised by professionals that separation would ease adjustment. Letters from patients, preserved in archives, reflect hope in early years and uncertainty later. For many, institutionalization became lifelong. The psychological cost cannot be calculated in census reports. It appears instead in posture, in silence, and in the absence of ordinary milestones. Pennhurst environment did not invent disability. It magnified it. Public reaction to Bill Baldini's 1968 broadcast was immediate. Journalists, advocacy groups, and families demanded investigation. Legislative hearings examined conditions inside state institutions. 4 years later, in 1972, national audiences would confront similar footage from the Willowbrook State School in Staten Island, New York, in a television investigation by journalist Geraldo Rivera.
This court is hearing the story for the first time, but it's an old story, and a story that goes even beyond the locked wards at Willowbrook and beyond the case that's being argued here. And tonight we tell that larger story, our version of the Willowbrook case, the people against the state of New York.
What happened on screens across the country in 1972 had already been visible in Pennsylvania and other states for years. The pattern was not regional, it was structural, and was embedded into the model itself. In 1974, a class action lawsuit was filed on behalf of Pennhurst residents. This class action lawsuit became known as Halderman versus Pennhurst State School and Hospital. Plaintiffs argued that conditions violated constitutional protections and federal disability statutes. In 1977, a federal court ruled that residents possessed a right to habitation in the least restrictive environment. That decision mandated development of community-based alternatives and reduced institutional numbers. Through the 1980s, residents transitioned into smaller community settings, and in December 1987, Pennhurst finally closed. Over its operational history, more than 10,000 individuals had lived within its buildings, and more than 2,340 are buried on its grounds, many marked by only numbered bricks. Pennhurst closure ended operation. However, it did not erase the memories. Today, the buildings remain. Brick walls, long corridors, and empty wards. Pennhurst represents a chapter in American social policy when institutionalization was considered progress. It reflects the belief that scientific authority could manage human difference through segregation, but history complicates that belief. Investigations by journalists such as Bill Baldini and later national coverage by Geraldo Rivera forced the public to confront what had been hidden behind institutional walls. Their reports help ignite a national conversation about dignity, rights, and the treatment of people with disabilities. And yet, the legacy of that era has not completely disappeared. Even today in Pennsylvania, some individuals with intellectual disabilities who are under court-appointed guardianship may still be required to seek approval from the Orphans Court before they are legally allowed to marry. Care requires resources, oversight requires transparency, and protection requires dignity. Alas, Pennhurst endures, not in architecture, and not in the consequences of its custody, but in the questions it leaves behind. What does society owe those placed in its keeping, and how do we ensure that that certainty never again replaces scrutiny? Silence fills the corridors now. But the record remains in their keeping.